So welcome everybody. This is our fifth session of our Intimate Partner Violence Primary Prevention Education Program. We are going to hear from Kristen Hall, one of our amazing emergency room nurses here at the University of Utah. She's going to be talking to you about communication and prevention strategies today. So using language and communication, language is very powerful, and we really want to focus on being able to speak with our patients and talk about prevention, which we've talked a little bit earlier is kind of a hard topic sometimes. No disclosures to let you guys know. We don't have any as the group that's putting this together. Kristen does not have any disclosures to tell you. This is our upcoming schedule. As you can see, we're starting today. We have a rebroadcast again in the morning as well. So if you know somebody that was not able to join, we have a rebroadcast of this tomorrow from 7:30 to 8:30. All right. We do just want to share that we've got some other folks on our campus working on prevention of sexual violence and fighting against gender-based violence. As you all know, October is Domestic Violence Awareness Month. So please also watch for posts and tips and tricks on our social media as well. You'll be able to see those. Our EMS Trauma Ground Rounds on current trends in toxicology. So you can go ahead and join us for that. And we have those second Wednesday of every other month from 2 to 3. We are going to turn it over to Kristen and let her start presenting and introduce herself and give us a little bit of background.
Hi, everyone. I am Kristen Hall. As Jamie mentioned, I am a nurse in the emergency department at the University of Utah, the main campus. My kind of secondary role is I do forensic nursing through the community. I'm the clinical director at the Family Justice Center downtown Salt Lake. It's on the YWCA campus. I kind of work with a few different agencies, the DA's office and law enforcement agencies around the valley doing training about domestic violence, particularly strangulation and sexual violence, and how to have a better response for these. Looking at a prevention strategies and how to bring this topic up earlier and help prevent is kind of a new spin on it. I would also like you guys to kind of think about what your current practice looks like in your place of employment, whether it be a clinic, an emergency department, a critical access hospital, kind of in the rural areas of the state. Any troubles that you guys have had and noticed on a regular basis in working with patients who are victims of sexual violence and intimate partner violence, and any frustrations that you guys have that we can kind of talk about as a group. The objectives, I'm hoping that at the end of this that we can help prepare you guys to confidently discuss intimate partner dating and sexual violence with your patients in more of a proactive manner and not just the reactionary lens that we kind of normally discuss it with. Understand what the exposure of violence on our patients has on their physical health, not only in the acute phase, but in the long term across our lifespan. And then hopefully we can help apply those trauma-informed practices into your patient care and improve kind of the dialogue we have with our patients on these somewhat difficult topics. This might be a review for a lot of you, but I just want to make sure that we're all kind of starting on the same page. Intimate partner violence is characterized as an unhealthy behavioral pattern with the intent of one partner to coerce, control, and victimize the other partner. It costs the United States $33 billion per year. So even if it does not directly involve us, we don't know anybody that might be a victim of intimate partner violence or sexual violence, we're all affected by it in some realm. 10 billion of that is in direct healthcare costs, and then 23 billion is in production loss. Our victims of violence aren't able to return to the workforce as they normally would, and they're it really alters their life from that point on. The goal when working with these patients is the safety and well-being of our staff as well as our patients. I put in staff first because these are the dangerous clients. I work downtown at the Level 1 Trauma Center, and these are the cases that worry me that are going to affect our staff, is the angry partner that's going to come and add harm to the rest of our staff as well as the person that they're trying to perpetrate against. Keep in mind that these can be very dangerous clientele to work with, particularly once that violence gets to that explosive stage. Have that safety plan in place for yourselves as well as your patients as we go through. And that's something that we can kind of discuss at the end as well. This obviously requires the collaboration of many disciplines. These are often intertwined with the criminal justice system. So you're working with law enforcement, victim advocates. It might go to court later on, so you might be working with the attorneys with the DA's office or defense attorneys, and just community partners, whether it be a shelter to find your patient a safe place to stay. The cycle of violence, we are all familiar with the cycle of violence. I throw this in here just to remind us that it is usually that cyclical pattern, and then often we are only seeing our patients, especially in emergency departments, kind of in this acute explosion phase. but it is part of a cycle generally. And a lot of times the only control the victim has in this cycle is the timing of it. They might, feel this tension building. They might know where they're going. They might feel like, he's getting more meaty. And I understand that it's not just strictly male on female violence. So I apologize if I slip into that, but affect every type of relationship, same-sex relationships, and then female against male perpetration as well. So they might be able to feel the tension building in their partner. They might see increased drinking and drugs, and then they might know that they're headed toward this explosion phase, but they might have like a family event that they want to prevent from ruining. So they might be going to Disneyland with their family the next week, and they want to get this over with. So they may pick a fight just to have that acute explosion happen on their time frame rather than have it ruin family trips or whatnot. And so when you see your patients, sometimes they might say, this is my fault, and it's very easy for them to internalize it and take the blame of that. But what I want you guys to understand is that even though they may have quote unquote picked the fight, or it might be their fault for this explosion, keep in mind that there is this cycle of violence, that a lot of grooming goes into this. There's a lot of control that their partner has on them. Understanding kind of where they are coming from and being able to meet them where they're at, it's very helpful when communicating with these patients that have experienced violence in their life. And then obviously the honeymoon phase, things go back to this beautiful lovey stage, which is what kind of keeps the relationship going and started that relationship in the beginning. So how prevalent is sexual violence? We're talking about in Utah, we are 1 in 3 women report experiencing domestic violence or intimate partner violence in their lifetime. This was a study from Southeast Asia, so just kind of looking on the opposite end of the world, that 30% of women aged 15 or older have experienced male perpetrated physical and or sexual IPV violence in a relationship. And then 7% of women reported non-partner sexual violence in their lifetime. That's scary that, we think about those stranger rapes that aren't necessarily the norm of what happens. Generally, rapes and sexual violence happen in the throes of a relationship, but still there's 10% of the population that is experiencing that terrifying episode of sexual violence that we all think about, the stranger in the bushes. Risk factors for intimate partner and sexual violence, and I hate kind of talking about risk factors when it talks to violence against another person, because it's not their fault that they're a victim of violence. If they didn't choose to be a victim of violence, nothing that they are doing is causing them to be a victim of violence. But there are certain risk factors that they may have experienced in their life, characteristics of their partners that may create that greater risk factor for them to be a victim of violence. Some of those risk factors are having a male partner with regular alcohol use. Any drug use by the victim or the patient increases their risk of being perpetrated against. Lack of fidelity, if you can just think of any stressors in a relationship. Unemployment obviously increases stress. And then any financial stress obviously cause additional stress to a relationship that can help increase the risk factors for intimate partner violence, and sometimes can be a trigger. And what I thought was interesting when I was doing some research is they were finding that having children and having more than one child decreases your risk of IPV. And this was a study done through the Air Force here in the States. And they found that once those couples or the couples that do have children and a family, their risk of IPV was a little bit lower, which is interesting. Children aren't necessarily a risk factor. And unfortunately, they're often secondary victims of violence. To understand the neurobiology of trauma and what happens with our patients' brains when they're exposed to a traumatic event. I put this in there because I want to talk about, especially with intimate partner violence, these patients are experiencing these triggers and this reaction to trauma on a regular basis. It was interesting when I started doing forensic exams on strictly sexual violence patients, so patients that reported being sexually assaulted. Meeting with them and talking to them, they would present in different ways, but often it was kind of, they seemed very withdrawn and shut down. It was difficult to engage with them in the exam, which was very understandable. And having, the advocacy piece there, and we're very lucky to have advocates up here in Salt Lake County that come and sit with our victims when they are going through these exams, just to have that additional emotional support. Seeing that as a stark contrast from when I started working with victims of intimate partner violence. Our program does a lot of strangulation exams currently, and meeting with those clients, it's very different dynamic. And it kind of took me a while to kind of figure out what was different that I was seeing. But these patients, they're able to sit down and they have a conversation like this is something that they do every day. They could very much be telling me like, they went to the mall, they went shopping, they're eating snacks, they're playing on their phone, they're doing, a whole bunch of different things. But this is something that is so ingrained in their lives and so much a norm to them that they just another day for them. Whereas working with patients of sexual violence, particularly those one episodes of dating violence, that this isn't a regular occurrence for them. It is that stark contrast in their reality. They went from having that typical life and working through our normal routines to being completely ripped out of their reality and that whole realm of trust being taken away from them. Looking at kind of what happens on a neurobiological level, Dr. Franchek mentioned that there's 3 different parts of the brain that are affected by trauma, and that this amygdala is kind of that smoke detector. It senses danger, and its sole responsibility is to keep us alive. So once that triggers, the important thing to realize is it kind of everything else in the brain shuts down besides the things that are there to keep us alive. So this prefrontal cortex that is responsible for our rational thinking, that shuts down. So our patients are not making rational thoughts at that. Their thought process and their decision making is controlled by the amygdala. So they may make decisions that they wouldn't think that they would have previously. Dr. Franchek told a story about one of her friends that was up in Alaska and encountered a bear. And kind of we all think like, if we ran into a bear, like what would we do? Would we stay and fight? Would we run? What would we do? But she had that reactionary, the freeze, where she couldn't articulate to her husband what was going on. She wasn't able to run away. And that was a decision that was made by her amygdala because that was her greatest chance for survival. And then looking at this hippocampus, this is very much responsible for our memory storage and filing those memories. So when that amygdala has taken over, we're not filing memories as we normally would. All the information is likely still there, where the patients and victims are still seeing and hearing everything that they normally would, but they're not processing it in a way that they normally do. So their filing cabinet is not filing in order. So this may be why when you sit down and talk to your patients about their experience, how they might not, especially in their acute phases, they might not have, a chronological timeline of what happened. They might not be able to tell you where they were or exact time frames of things. And that's totally a normal response because that amygdala was not, or that hippocampus was not working as it should. They were completely in their reptilian brain, as they call it, and the amygdala was responsible for keeping them alive. Even though kind of, especially in emergency medicine, we go in and we want to know, A, B, C, and D so that we can help provide for these patients. Well, often that is not the best case or the best method in eliciting information from them and working with them and getting on their level and helping them through what has happened. Oftentimes you have to slow down, sit down and talk to them, help them figure out what they need at that point in time, and then kind of work through it that way. And we'll talk a little bit later about how to kind of elicit some of that information. So primary for prevention, as I mentioned, that's kind of what the trauma program is focusing on, how to prevent IPV and sexual violence. When I say IPV, I'm talking about intimate partner violence, also a synonym for domestic violence. You can use whatever terms our state coalition has chosen to go with domestic violence. So that is one that we still use here in the city of Utah. It is a little bit antiquated, and intimate partner violence, gender-based violence is kind of where the lingo is going. So looking at primary prevention, so remember, this is the type of prevention where our patients have not been exposed to any type of violence yet. So we're looking at preventing it altogether. Once we're talking to an adult patient, it's kind of, we're behind the 8 ball a little bit, making sure that they have decreased risk factors of intimate partner violence. Kind of goes all the way back to childhood. Dr. Franchek mentioned a little bit about the ACE scores, the Adverse Childhood Experience scores. This has been a research movement in probably the last 5-10 years, where they're associating our childhood experiences and noticing how much of an increased risk that puts on our health, as well as suicidality, depression, anxiety, chronic diseases, diabetes, COPD, heart disease. It increased ACE scores result in higher levels of these types of diseases later on in life. They are also associated with an increase in a risk factor for intimate partner and sexual violence in adulthood. And looking at the ACE scores, there's 3 different categories. There's abuse, neglect, and household challenges. The abuse is broken up into physical, sexual, and emotional, and it asks if you were ever exposed to any one of these. It's a questionnaire. You guys can Google it and fill out and figure out what your ACE score is. The neglect category breaks it into emotional, physical. Were they ever emotionally neglected by a parent or an adult in their lives, or had any sort of physical abuse by adult in their life? And then looking at household challenges, was anybody in the house did they have a substance abuse problem? Divorce in the family, they consider an adverse childhood experience, which is fairly common here in our society these days. Was there a member of the family that had mental illness? Did they witness violence towards their mother? That is a huge risk factor for intimate partner violence and sexual violence later on. And then was there a member of the family that was incarcerated at any point in their childhood? That also increases their risk for a lot of these diseases. So substance abuse, obesity, diabetes, heart disease, stroke. And it's very interesting how just these seemingly smaller adverse childhood experiences, I say smaller, like maybe a divorce that is fairly common, can add to increased physical health problems later on in your life. So this is a poll. I want you guys to think about how common are ACE scores and what percentage of the population has at least one adverse childhood experience in their life. It looks like most people guess that 66% of us have at least one adverse childhood score. 38% was the next guess, and that's 17% of you. No one guessed 12, and no one guessed 24. Looking at how common are ACEs, this was from a 2011 to 2014 survey. 24% of the population has at least one ACE score. What I thought was interesting about this research is even though 0 was the most common and at least one ACE score was the next most common, then you jump to 4 or more. So you either have one ACE score or you have 4 or more ACE scores. So question 2, looking at the ACE scores, how many people do you feel grew up in a home with substance abuse? Most of you guessed that 49% or half of the people polled had experienced or grew up in a home with substance abuse. No one guessed 12%. One of you guessed 27%, and a couple of you guessed 35%. 27% of people report being in a home with substance. What I thought was interesting is that was more than those that had experienced a separation or divorce in their household. So substance abuse is a fairly common ACE score for a lot of individuals. And looking at alcohol use and other recreational substances can really affect childhood experiences, as well as affect their health later on in life. Abuse, 28% of them experienced physical abuse, and then 21% experienced sexual abuse. So those people that had at least one ACE score, almost a quarter of them experienced sexual violence. A mother treated violently, 13% of them. I think that's probably fairly common in a lot of these households, and definitely increases the risk for IPV as well as sexual violence later on. And then emotional and physical abuse. Looking at ACE prevention. So again, like I said, when you're working with adult patients, you obviously can't go back in time and take away, their ACE scores and take away their parents' alcoholism problem, or, get their older brother out of jail or whatever their ACE scores may have been. But we can start looking at kind of the next generation and breaking that cycle and preventing continuation of these ACE scores from affecting not only IPV and sexual violence, but all those other health problems later on in life. By strengthening economic supports with families, any family-friendly work policies, I think that increases, it helps with job satisfaction, not having a strict family versus work dynamic. Anybody that can feel like that their family is appreciated in the workplace, I think gives a lot to job satisfaction. Change to social norms to support parents about positive parenting. Legislative approaches to reduce corporal punishment, and we're not talking about like a spank or a slap on the hand or whatnot. We're talking about severe beatings with belts and whatnot that they're steering away from, and there's a lot of research that has gone away from that. Public engagement and enhancement campaigns on the dangers of negative reinforcement parenting, and really supporting that positive parenting is, I think, a huge. Early education later on, education early in life, you're looking at supporting the teachers in your district, in your area, and supporting that early education. That's not just, giving your kids a good education and the kids in your community, but that is also affecting their health. Providing that preschool enrichment with family engagement and having those, active PTAs and enough finances to have that quality childcare, I think is a huge asset to preventing these adverse scores. Enhancing parenting skills and teaching our parents how to help their kids in the home and not just relying solely on them going to school and learning things. What does that look like at home, and how do you help your child achieve those childhood development milestones in the home? I think is a huge thing as well. Prevent future risk. Obviously, enhanced primary care and access to healthcare is a huge problem for rural areas, especially low-income families, making sure that they are available to receive vaccines and primary care, especially in these milestone ages where we can make sure that the kids are developing as they should. Secondary prevention, I think this is where a lot of IPV trainings focus. This is where we talk about screenings. Remember, this secondary prevention is where our patients are experiencing violence, but maybe not having any symptoms of violence. Looking at this, these are what I borrowed from Dr. Franchek's presentation, and this is kind of through the policies at the University of Utah. So we're happy, and Dr. Franchek is very willing to share all of the research and tools that she has created. So she's created these smart mnemonics and diagrams that you can kind of work through when working with these patients, particularly in rural communities where this might not be something that you have seen every day, or are starting to kind of improve our response to screening with these types of patients. And this is something that we're currently working on at the main campus in the emergency department as well, is increasing kind of our dialogue and streamlining and creating scripting so it makes it more comfortable for people to have this kind of difficult conversation, somewhat intimidating conversation with their patients. I like to sit down and educate my patients. In the emergency department, it's very difficult. I know when we're triaging our patients to kind of get all the important information, and this may seem like a frivolous thing that we have to do, and it's historically has been, do you feel safe at home is the only question that we get. I feel that it's helpful to use that as an educational opportunity. It doesn't have to be anything, big, long, and wordy. You need to take 10 minutes talking to them about intimate partner violence and sexual violence, but just creating the opportunity for them to understand that this is a place that they can get help. So I always start by educating and saying, unfortunately, domestic violence is fairly common in our society. Just know that you're welcome to come here if you ever feel that you're in danger, or if you don't know where to go. We have resources here available for you, or if you or a friend need those resources. The U.S. Services Preventative Task Force have created the screening recommendations for any women of reproductive age, that we should be screening all of the women of reproductive age for intimate partner violence. And those screenings should be direct and should be somewhat scripted so that it's an easy conversation to have. The one that we have adopted at the University of Utah is the HARCS or SHARC. You can do either way. I like strangled at the top just because it highlights kind of an important kind of triage decision making, and that's can signify some great injury there. So I usually start by educating my patients, saying domestic violence is fairly common in our society. We like to ask our patients if they feel safe at home in their current relationships, because just asking if they feel safe at home, that could be, are there rugs that you trip on? Do you have the appropriate smoke detector equipment? So it really should be a relationship focused, and educating them that I'm not asking them because I feel like they're leading me to the point where I should. I'm asking it because it's something that is common, and so it's something that normalizes it for them, and so they're not the only one that is experiencing this. They choose not to disclose today, it opens the door for them in the future, so that they know that this is a place that they can disclose that they're being hurt by somebody, and find those resources, and hopefully kind of get on a safer path and healthier path, as Dr. Franchek mentioned. If your patients do not fit in that women of reproductive age categories, there's no research that says we absolutely should be screening them. But the recommendations are anybody with risk factors. So if you feel like they have any increased risk factors for IPV or sexual violence, just having maybe an indirect conversation with them is not a bad idea, and just letting them know that this is a place that they can present for help. But the indirect method that Dr. Franchik has kind of written out is many people experience an unhealthy relationship at some point. These types of relationships can really affect your health. We want you to know that if this ever happens to you, you can come to us for help. And I like that she has changed. Do you feel like you're in a safe relationship? Safe has kind of a negative connotation because it could be the safest relationship that they've been in. They might not be harming, or they might not be physically harmed by that relationship, but it's not necessarily the healthiest relationship. Once you have a positive screen, this kind of walks you through what you need to do from there. And these, as I said, Dr. Franchik is happy for you guys to use, and we can send them out. And if you're in the University of Utah network, they are on our Pulse site so that you can pull these up, and they all have the hyperlinks so that you can click on them and go to the general resource list. And then just to highlight, any assaultive injury that you are treating or documenting on needs to be reported to law enforcement, whether or not, even if a weapon was not involved, any injury that was caused by another person should be reported to law enforcement. That is a state law. So if you have any questions about that, there's the statute that is linked to, I think, the bigger algorithm that supports that. Another thing that is important to mention is these screenings and these discussions should only happen if the patient is alone. That is one benefit we've had from Corona in the COVID response, is that we've had a no visitor policy. So having these conversations with our patients has been very kind of a lot easier than historically has been, getting them apart from their family and family member and having those difficult conversations. If you absolutely cannot get them alone, this screening should be deferred. And then I would just give them a resource list at the end and just say, these are just community resources. If you ever feel like you need them, please do not screen them in front of anyone, whether it be their partner, their best friend, their cousin, their mom. You don't know who's hurting them at home, and that can actually increase their danger once they get back home. Keep that in mind, that these screenings should only be done, and this conversation should only be had alone with the patient. So this pulls this up. As I said, the HARCS or the SHARC is the screening tool we used. Have you ever been humiliated or emotionally abused by a partner? Have you ever been afraid of a partner? Have you ever been raped or forced to have sex by a partner, kicked, hit, slapped, or hurt by a partner? This is meant to be ever in their life, even if it's not currently, as we're learning that previous abuse can have a direct effect on the relationship. So we like to know if they've ever had a history of it. If they say, no, I'm in a great relationship, say that's wonderful. If you ever need it, please remember that we're here to help you. Similar things with disclosure of sexual violence. We ask if they've, in HARCS, it asks about sexual violence, if they've ever been raped or forced to have sex by somebody. But most of your disclosures of sexual violence, I think, are going to come along with patients that are looking for a sexual assault exam. It's not something that you necessarily have to elicit out of them. They usually are pretty forthcoming that that's what they're there for. Treat the symptoms, and then ask patient and privately if they've ever been touched against their will. If you're starting to see a lot of these injuries and they have not disclosed, it might be beneficial to have this conversation in private and just make sure that nobody is hurting them. As Dr. Branchik mentioned, if you guys are in a community clinic and you have patients that are presenting with multiple encounters with sexually transmitted infections, it may be warranted to have kind of a more in-depth conversation about sexual violence and if they're being harmed by anyone. The algorithm goes through and kind of guides you from there. I'm not going to spend a whole lot of time on there, but they are available for you guys to look at and go through later. So when we talk about why do they stay, what has our patients have experienced, and meeting them where they're at rather than expecting them to rise to our level when we're helping them. Particularly if you're seeing these patients in like a community clinic and you're in a small rural area and you see these patients over and over again, it can be very frustrating. A lot of our EMS crews and PD law enforcement, they get frustrated going to the same house every day, responding to domestic violence problems. So it's a good reminder for them that there's a lot of reasons why they do stay. It might be that they are economically or financially dependent on them. They may have been isolated from their support system. They may have moved across the country and they have no support outside of their spouse or their abuser. Children are a huge one. One of my patients who actively being abused by her husband, she was so terrified and needed to get home at a certain time, because if she wasn't home by the time he left for work, he was just going to leave the child there. She mentioned to me that, she's concerned about if she leaves him, she knows that he's going to get 50-50 custody of the child. That leaves the child without her protection. So at least they're being abused under like her protection rather than the children going to, the other parent's house, the abuser's home, and having those unsupervised visits. So that's a huge concern for a lot of the victims that I've worked with. And then there's always that love and hope for change. There's a reason why the relationship started in the beginning. Nobody goes into a relationship wanting to be abused. So they always are hoping for that change. Abusers are very good at dangling that carrot, saying, as soon as I get this promotion, I'll be a lot less stressed. I won't be so angry all the time. This and this happens, it'll get better. So they're really good at dangling that carrot, saying that things will get better, when oftentimes they won't. And religious and cultural beliefs are a big thing here. We have a very patriarchal society, which isn't necessarily a bad thing. I'm not saying all patriarchal relationships are abusive, but growing up in that can create kind of trends and kind of facilitate abusive relationships, and kind of isolate victims away from the support that they might need to get out of it and to speak up from it. So there may be some dynamics that we're not fully aware of. I love this quote by Nikita Gill: when you ask someone why they stayed when they could have left the heartache and the pain, remember there are days when even you have chosen the hell you know over the hell you don't. So we don't know everything that they're going through. We're all guilty of choosing the easiest path, the path of least resistance, and for them, what they know is the easiest. It's hard for them to imagine what their life looks like without it. And I'll kind of go into that in another slide here in just a second. I'd like to throw the kind of blame back on the abuser. Why does he or she choose to abuse? It's not our victims, our patients' fault that they are being abused. We need to throw that back on the perpetrator and ask why they're choosing to abuse. What has happened to them that has led them to this? And then obviously the tertiary prevention is once our patients are starting to experience symptoms from the violence that they have experienced. In a 2002 study, they showed that abused women had a higher prevalence of headaches, back pain, sexually transmitted infections, urinary tract infections, abdominal and pelvic pain. Strangled women also have a higher incidence of stroke and TIAs, or mini strokes. That's a whole different topic and lecture. And then a lot of these who have experienced repeated injuries to the brain, whether the 3B through an anoxic brain injury from being strangled or traumatic brain injury from being hit. Keep in mind that those brain injuries are cumulative and our brains are never the same as they once were. We're also learning that victims of intimate partner violence have more traumatic brain injuries than NFL players. So I'm going to just do a little bit of a tangent and then we'll kind of get into your questions and whatnot. But looking at domestic violence and head injuries. So if IPV victims have more traumatic brain injuries than NFL players, and you look at this article done by Time magazine saying that 110 of 111 NFL players tested positive for CTE after they donated, their brains to science and had an autopsy after they had passed away. It's probably fair to say that almost all of our patients who have had repeated head injuries, whether it be, like I said, anoxic brain injuries from being strangled or blows to the head, that they are probably also positive for CTE. So those of you that aren't familiar, it's chronic traumatic encephalopathy. It's brain atrophy degeneration from being hit in the head or multiple head injuries from that anoxic brain injury as well. I'm not going to go through this list, but just keep in mind that look at the symptoms and kind of look at how many of your patients are experiencing these symptoms. And if you can kind of look at those symptoms and say, what came first, the chicken or the egg? Are they normally irritable and aggressive with suicidal thoughts, or is that a response to previous abuse? The other one I want to point out is patients with CTE have difficulty planning and carrying out tasks or having that executive function. So when we ask them, like, why do they stay? It may be the case that they don't have the executive function to plan a life outside of that. They're literally stuck in the hell that they know, and without outside intervention, it's not going to happen that they're going to get out of their unhealthy relationship. So red flags, these are very difficult to kind of pinpoint. Most of these red flags are probably you're going to see in extreme abuse situations once it's getting to the very dangerous point for that patient. If they are fearful, if they have lack of control, they seem overly submissive to their family member that is there, that's always a red flag for me. And I try to make an excuse to get them out of the room. I take them to the bathroom, take them to the radiology, and have kind of a more in-depth conversation with them, making sure that they feel comfortable at home and that they're in a healthy relationship. At least give them the opportunity to disclose if they would like to. Obviously, any evidence of abuse, if they're accompanied by a controlling person, keep in mind security. No one has a right to be in your facility. So if there's somebody that's causing problems, we can be the bad guy and we can keep that patient or the controlling person away from that patient and really kind of be able to keep that patient safe for at least a few hours while we figure out another plan for them. Their inconsistent history, whether that be from, their trauma brain and they're unable to kind of tell you what happened, or if the story doesn't match the injury, we all know that's a red flag. If they seem to be in a rush to get out, as I mentioned, my patient had to be home at a certain time, otherwise she was going to get in a lot of trouble. If they're constantly on their cell phones, if they have their cell phone in the lap, be aware that your patient's abuser may be listening in on your conversation. So put cell phones away, make sure that they're not sitting out in the open. They may be recording your conversation. Just keep that in mind that is something that abusers tend to use. If they have frequent visits, UTIs, unexplained medical conditions, those are obvious red flags as well. I put this in here just to remind you that nobody experiences trauma in the same way as another person. I could have a traumatic event and I could have that startle response. I could have nightmares and flashbacks, where another person might dissociate completely, have a loss of interest in everything and just become very flat with self-destructive behaviors. It just depends. It's all completely 100% normal, and no one is going to have the same response. They might be laughing and giggling and just seemingly fine and able to kind of articulate what's been going on with their abuse, but that's just how they are processing their trauma. So we're going to, let's see, I'm just going to have you watch a few minutes of this video and then we'll jump into questions. Just Start by Believing is a campaign that was started by the End Violence Against Women International Program to kind of, like I said, meet these patients where they're at. A lot of patients fail to disclose abuse, especially sexual violence, because they feel like they're not going to be believed. It's something that we're really trying to change our mindset, and really, once they do decide to disclose, please sit down with them, take that opportunity, and tell them you believe them and be there for them. I'm just going to skip to this next slide, just to the trauma-informed takeaways in the one of that video. Take that time to have that private conversation, sit down on their level. Take the few minutes out of your day. I understand that a lot of you work in emergency departments and you might not feel like you have the time. Take the time to have this conversation with the patients. It's very important for their health and it can keep them alive. Know your resources at your facility and your community. Know where to send them if they do disclose that they've been abused by somebody. Know what resources are available. Do you have a caseworker in your facility that you can kind of point them to, or a crisis worker that can give them resources and have that more in-depth conversation? The YWCA has great resources with the Family Justice Center for patients who are experiencing intimate partner violence or sexual violence. So know what you have down there, or down in your rural areas. If you need help, please reach out to me and I'm happy to plug you in with people that can be there for you. There's a lot of government funded programs that are there for your patients. Something that is very important once you start screening patients for intimate partner and sexual violence is to kind of be consistent throughout your staff. There's nothing scares me more than me having these conversations with my patients saying, if you're ever in this situation and you feel like you need help, please come to us. And then I'm not there the next week when they choose to come disclose, and that patient or that nurse that's taking care of them fails to allow them the opportunity to disclose. It takes a lot for point they will disclose, and so not giving them the opportunity is something that it terrifies me. So I'm hoping that we can be consistent and kind of get that scripted dialogue so that everybody has the opportunity. Educate and empower your patients to seek healthy relationships. Have these blunt, frank conversations with them. It helps them, understand that they're not alone in their situation, and that there is a healthy relationship and a healthy path for them going forward. And then, as I mentioned in the beginning, know how to build your safety plan, not only for your patients, but have one for your staff as well. Know your panic buttons, how to contact PD or security to keep everyone safe, because these are the volatile cases that end up in very bad ways. Okay, we're going to go back and start a little bit of this video, and then we'll save 5 minutes for questions. Just guys get forward in time, but you can Google this, or I can send you the video. It just goes through different um, experiences that patients had that have been sexually assaulted and the responses of the community, how we failed them because we didn't believe them initially, or we were worried about ruining the rapist's life rather than helping them meeting them where they're at and helping them out of their abusive relationship. So they started the Start Believing By campaign and as a way to move forward. Just want to leave time for questions, but this is a great movement if you guys are ever interested in creating a Start By Believing campaign. We are a Start By Believing state in the state of Utah. Start By Believing Day is the first Wednesday in April. So it's something that we do on a community level if you guys want to get.
All right. Thank you very much, Kristen. Where we want to lead back to is what is leading these people to perpetrate in the first place. And hopefully we can stop the violence from happening. And stop these people from being victims before it starts. It's a long road. We appreciate you coming in and presenting today.
I have a question. I'm just wondering
Yeah.
your experience in the actual ED. Is this conversations that are happening among staff members, be discussing with each other? Are people talking, are staff talking about it, or is it just kind of a movement that's happening within individuals and maybe individuals that are having those conversations?
I think that we are getting a lot better. I've worked at a few different emergency departments in my years as a nurse, and it's definitely evolving over the last few years. I mean, before I became a forensic nurse and started doing sexual assault exams and domestic violence exams, I was, guilty of having those thought processes that, oh, she's probably just trying to, get out, not feel guilty for having sex last night. And I was guilty of those victim blaming behaviors. I think we are getting better. I think we're understanding more about taking that blame off that victim and just helping them and being there for them in their time of need. I think we're doing a great job at the University of Utah. Dr. Franchuk is doing a wonderful job with our Committee on Domestic Violence and creating hospital-wide and campus-wide policies on, bettering our response. So I would say that the University of Utah is the most positive, proactive change place that I've been. But I think it is slowly evolving around our communities. Utah, we're a little bit slow in talking about intimate partner violence in general, but I think it is happening, especially in the larger communities for sure.
One other question in your forensic role, have there been any discussions that you've had with victims at all that maybe what they experienced within a emergency department or clinic that could be used to all of us? Oh, we should think about that in our practical everyday roles.
Yeah, I think that probably the biggest takeaway from me is that I've worked in the emergency department and I've been a forensic nurse responding to sexual assault in the emergency department. And I think we're lucky to have multiple options for our patients to get their sexual assault exams. They can either present to emergency departments throughout most of the state of Utah, or they can go to the community clinics if that's where they feel more comfortable. And the forensic nursing side of things is just kind of that victim blaming behavior from staff, and be aware of how much you say, what kind of portrays to your victim. Even if you don't believe what happened to them, that has no bearing in your care. And it doesn't matter whether or not they're lying or whether or not they're, trying to get attention. They were presented to the emergency department because they are reporting they were sexually assaulted. They are reporting they were hurt by somebody. We have the duty to sit down and believe our patients, whether they're presenting for abdominal pain or chest pain or sexual violence. We have the duty to sit down and meet them where they're at and say, how can I help you? Because whether or not they're lying or trying drug seeking or whatnot, just being aware of those behaviors and those kind of jaded behaviors that we might have be guilty of as emergency department nurses. Be aware of how that might come across to your patients, and particularly what you might be saying out of the desk that they might be overhearing.
I have a quick question just about your experience and talking to some of these victims that you have seen and talked to. Part of primary prevention is maybe catching them in this honeymoon phase, or at the beginning of that tension building. And in your opinion, I know that we can look at statistics otherwise, but how many do you think, if we could get them resources and get them aware of the situation they're going into, that possibly might have that strength to leave earlier before a lot of the violence, especially the worsening violence, starts?
I think it's very difficult, and it's going to be very patient dependent, but I think people stay in relationships that might be just initially scary, going to like, ooh, that's a little bit of a red flag, but I'm going to kind of wait it out because maybe they don't have the resources available. Maybe they're financially dependent on them, or that, he buys me a lot of nice things. So I'm just going to play this out a little bit longer, where if we can provide our patients with the resources they need to live a healthy life, I think that is going to be a huge benefit to them. And that will be the kind of game changer in them escaping these relationships early on. So by utilizing the dot resource phrase in Dr. Franchuk's presentation, putting that resource list in all of your discharge instructions, and say, you know what, I know that you may not need this, but at some point you might know somebody that might need help finding a job, or that might need temporary housing, or that might just need a safe place to stay, might need drop-in childcare to make an appointment. So even if you don't need this, just educating them and giving them the tools to empower them to leave a relationship early on, I think is the huge game changer for them.
And I am going to say, you talking about resources, that is something that we're working on building as kind of a resource booklet. And we were trying to make it specific, especially if rural areas are asking for resources, putting things in discharge instructions, things like that, for us to be able to help them. So that is going to be part of this program, to be able to put that together and send it out later on.
For sure. And then if anybody has any questions offline, my email's at the end. You're welcome to shoot me an email or text, whatever, and I'm happy to help you guys, specifically in rural areas, kind of plug you into resources.
Okay, well, Kristen, thank you again for taking the time.
Oh, you're welcome.
Great information.